this video, we will be focusing on the specific pharmacologic agents used for the treatment of acute myeloid leukemia, or AML, and multiple myeloma that are included in the IQ cases this week. Now, keep in mind there are other treatment options out there, but for this video, we will narrow in on the anti-cancer agents used in these particular cases, and we will start off first by focusing on AML. AML is characterized by the accumulation of genetic changes altering normal hematopoiesis. So these mutations result in the clonal expansion of undifferentiated precursors of myeloid white blood cells, or myeloblasts, in the peripheral blood and bone marrow that do not mature. They proliferate unregulated and evade apoptosis, resulting in ineffective hematopoiesis. So this leads to signs and symptoms of AML being very similar to those of anemia, thrombocytopenia, and neutropenia. So, for instance, fatigue, bleeding, and infections. And one thing I do want to point out is remember how conventional chemotherapies come with mutagenic risk and the risk of other cancers later on in life. Well, exposure to alkylating anti-cancer agents significantly increases the patient's risk of AML after receiving the alkylating chemotherapy regimen to treat their other cancer. So now I will not go into further detail of the pathophysiology of AML, which you will extensively cover in your IQ discussion, and we will transition to the treatment regimen included in this week's case. Now, I've left the schematic here as a reminder that's very common for agents from different classes to be combined together to target the cancer cells via a number of different mechanisms, ideally mitigating resistance and picking agents to avoid overlapping toxicities as much as possible. And specifically for AML, we will be discussing 7+3 induction therapy. And this stands for 7 days of standard dose cytarabine, which you also might see referred to as Ara-C, and 3 days of an anthracycline like daunorubicin. So in this portion of the video, we are going to discuss our anti-metabolite nucleoside analog, being our cytarabine, and revisit the anthracyclines with daunorubicin, which we discussed last week. We are also going to discuss midostaurin, which is our targeted therapy used in AML in this case. So the goal of therapy would ideally be to induce remission, and then this can be followed with consolidation therapy like high-dose cytarabine or a stem cell transplant with the intent to cure. So moving to our next slide. So moving on to the specifics of daunorubicin, cytarabine, and midostaurin. So we will start with daunorubicin, which I will not spend too much time on because it belongs to that anthracycline class of agents, just like doxorubicin, which we discussed in depth in the non-Hodgkin's lymphoma video. So there are a lot of similarities regarding mechanism of action and pharmacologic considerations. So just as a brief refresher, daunorubicin, like the other anthracyclines, will intercalate into DNA, blocking replication, and this will interact with topoisomerase II, inhibiting its normal function, causing DNA breaks to eventually trigger apoptosis in our malignant myeloblasts. And remember, the big adverse drug reaction for this agent is cardiotoxicity. So now on to cytarabine, which, as I said before, is an anti-metabolite agent, and this means that it acts as a false substrate in some sort of biochemical reaction involved with DNA synthesis. So this agent is a nucleoside analog that enters malignant myeloblasts through the already present nucleoside transporter on the cell membrane. And once inside the cell, this pyrimidine analog is triphosphorylated to arabinosyl cytosine triphosphate, or ARA-CTP. And once in its active form, it can compete with the normal pool of DCTP, leading to the competitive inhibition of DNA polymerase and inhibition of DNA synthesis. But this agent can also be misincorporated into newly synthesized DNA, as a dummy nucleotide, and this lesion may induce apoptosis if left uncorrected. Now, many of the ADRs of conventional chemotherapies we discussed in the non-Hodgkin's lymphoma video will be applicable to cytarabine, including our GI-related ADRs, as well as bone marrow suppression. And then more specific to cytarabine, depending upon the dose and route of administration, there is a risk of severe and potentially fatal neurotoxicity, like cerebellar toxicity and ataxia, and even coma. And this risk increases with higher doses, intrathecal administration, or hepatic or renal dysfunction. So moving forward from our conventional cytotoxic chemo to our targeted agent being midostaurin, which is indicated for AML patients with an FLT3 mutation, in addition to the cytarabine and daunorubicin regimen we discussed before. So now the FLT3 receptor, or the cytokine FMS-like tyrosine kinase 3 receptor, is expressed on myeloid progenitors, and when bound by the FLT3 ligand, triggers important regulatory cascades for hematopoiesis and promotes the growth and differentiation of hematopoietic lineages. In AML, the gene encoding the FLT3 receptor commonly acquires either internal tandem duplications, or ITDs, in the juxtamembrane domain, or point mutations in the tyrosine kinase domain. These mutations are all constitutively activating, leading to ligand-independent FLT3 receptor signaling, leading to downstream activation of transcriptional pathways, promoting the proliferation and survival, and inhibiting apoptosis in our malignant cellular population. And this is where midostaurin comes in. And midostaurin is a small molecule tyrosine kinase inhibitor, capable of inhibiting this unregulated FLT3 tyrosine kinase receptor signaling, which will inhibit cell proliferation and promote apoptosis in myeloblasts. Now, unfortunately, this is not the most selective tyrosine kinase inhibitor, which leads to the inhibition of other tyrosine kinases, which is not ideal when trying to minimize adverse drug reactions of particularly toxic anti-cancer regimens. So some of the notable toxicities of this targeted, quotes, agent are actually still very similar to the conventional chemotherapies, because the rapidly dividing cell populations still need functional tyrosine kinase signaling. So we're still going to see that bone marrow suppression and the GI adverse drug reactions, including a couple unique concerns specific to this agent, including hyperglycemia, QT prolongation, and pulmonary toxicity. So moving to our next slide. So now I hope the first half of this video provided a nice overview of the agents used for the treatment of AML included in this week's IQ case. And now we will switch gears to multiple myeloma. So moving to our next slide. So multiple myeloma is a plasma cell proliferative disorder characterized by the abnormal increase in monoclonal antibody production. And the exact etiology of multiple myeloma is unknown. However, frequent genetic alterations and chromosomal translocations likely play a key role in disease development. Now, regardless of the molecular driver, once there is an excess of monoclonal antibodies being produced, there is a risk of hyperviscosity and renal tubular damage can occur, and this can lead further to neurologic problems and renal failure, respectively. Bone marrow occupation by that expanding plasma cell clonal population usually will manifest as anemia, thrombocytopenia, and neutropenia. And the last concern I will mention is the interaction between the myeloma cells and the bone ultimately will lead to the activation of osteoclasts and a suppression of osteoblasts. So this will result in bone loss and lytic lesions. So based on this list of clinical manifestations, there are a number of supportive treatments that may be necessary for a patient with multiple myeloma, in addition to their anti-cancer regimen, like the bisphosphonates, like zoledronic acid, that is mentioned in this week's IQ case. However, we have already gone over bisphosphonates in a previous video, so our focus today will purely be on the specific anti-cancer agents used to treat the patient in the IQ case, which will include lenalidomide and dexamethasone, which are miscellaneous agents, and bortezomib and daratumumab, which are going to be more of our targeted agents. So moving to the next slide. So we won't discuss dexamethasone in detail because we've already extensively covered the corticosteroids in a number of different contexts, and it's still going to go through that same signaling cascade we discussed before, where we're repressing genes required for proliferation and survival and inflammation, and the promotion of genes leading to apoptosis of malignant cells. So for the sake of time, we will not revisit the pharmacologic considerations for this group of agents, but you should start becoming really familiar with that long list of adverse drug reactions for corticosteroids. Now moving forward to discuss lenalidomide. So this agent's mechanism of action is still not fully elucidated, but it's thought to mediate its effects through a number of mechanisms that all promote the apoptosis of malignant plasma cells. So this may include the repression of cytokine, pro-angiogenic factor and adhesion molecule production, as well as other pro-inflammatory proliferation and survival signals. It's also thought to promote apoptotic signals. And importantly, lenalidomide has effects on other cellular populations. For instance, enhancing the body's immune function by promoting cytotoxic T cell and natural killer cell mediated cytotoxicity of malignant plasma cells. So together, all of these effects make this therapy a staple for multiple myeloma treatment. As for adverse drug reactions, this agent is a derivative of thalidomide, which has clear demonstrated teratogenic effects. And this is a black box warning, as well as bone marrow suppression and venous thromboembolism. Beyond black box warnings, there's also a risk of hepatotoxicity and rash that can be severe, including Stevens-Johnson syndrome. Now on to our next agent for this video, which is going to be bortezomib, which is a targeted agent specifically inhibiting proteasomes. But before we get into its mechanism of action, first let's go over why proteasome targeting is important in multiple myeloma. And we will start off at the level of the nuclear factor kappa light chain enhancer of activated B cells, or NF-kappa B, which is highly involved in multiple myeloma. So NF-kappa B is a transcription factor typically bound in its inactive form by its inhibitor protein, I-kappa B, in the cytosol. But when cytokines bind their cytokine receptor or some other cellular stimuli occurs, this triggers a signaling cascade that tags the inhibitor of kappa B for degradation by the proteasome. Once the inhibitor of kappa B is degraded, then NF-kappa B in its active form can now translocate to the nucleus to promote the expression of genes involved in angiogenesis, adhesion, proliferation, and survival, as well as repress apoptotic genes. Now, bortezomib is an inhibitor of proteasomes, and this will prevent the degradation of the inhibitor of kappa B. So these levels are higher and more NF-kappa B remains inactive. So we do not get these downstream effects. Because of NF-kappa B's involvement in multiple myeloma, this agent is added to the previous regimen of lenalidomide and dexamethasone. As for ADRs, the biggest one for bortezomib is neuropathy, in addition to bone marrow suppression, specifically the neutropenia and the thrombocytopenia. And generally, adverse drug reactions for this agent are considered relatively less severe when compared to those conventional cytotoxic chemotherapies. And now the last agent we're going to discuss is going to be daratumumab. And hopefully, looking at this name, you think monoclonal antibody, specifically a human monoclonal antibody against some sort of tumor target. And in this case, our target is going to be CD38. And CD38 is expressed on plasma cells, which makes sense for treating myeloma, right? Where this antibody will bind to CD38 and decorate these malignant cells on the surface, and then tag them for destruction and clearance from the body by various immune-mediated cytotoxicity pathways. So thinking complement, natural killer cells, macrophages. And it is thought that this binding is also going to lead to some direct triggering of apoptosis as well. So it also may reduce some of the suppressive effects on regulatory immune cells so that you can actually be able to trigger a more robust response against the myeloma cells when giving this drug. And for pharmacologic considerations, this agent is pretty well tolerated, but like most monoclonal antibodies, we can see some infusion reactions. So we will need to have some monitoring as well as some pre-medication in place. And as you might expect with an agent like this, there's going to be a risk for infection as well as some immunologic and hematologic effects just because of the imbalance this agent is causing. But also, these are going to overlap for the drug and the disease, so it's going to be a little more difficult to suss out. But one of the other more important things to note for this agent is CD38 is present on our red blood cells. So that means this agent is going to interfere with blood typing and screening tests. So this needs to be done prior to the patient starting this agent. So moving on to our summary slide. So I hope this video has provided a good introduction to the primary treatment regimen used for multiple myeloma, as well as AML, which we addressed in the first half of this video. Again, we'll continue to go over more and more anti-cancer treatment options that you can combine with all the other ones that we've addressed in this block, as well as the ones you encountered in block 2, so that you'll have a good grasp on all of these different mechanisms of action and adverse drug reaction profiles of these different agents we combine to create these treatment regimens.